Okay. Uh, Risk factors for leg call Perthes disease are except. Can you read? Okay. Positive family history, passive smoking, male gender, growth abnormalities. Please remember, leg call Perthes is seen in young children between 4 to 8 years. Okay. So you rule out one by one. Passive smoking, unlikely. Male children, yes. Growth hormone abnormal, positive family history. The answer is growth hormone abnormalities. Please remember, growth hormone abnormalities is relevant in slipped capital femoral epiphysis, which I'll come to that later. Here, the answer for the risk factors for leg call Perthes or only Perthes, all are risk factors except growth hormone abnormalities. Please remember this. Okay. Which of the following is a X-ray feature? X-ray feature of Perthes disease. Today I think I had a message. What are we going to deal with? Today we are dealing with Perthes slipped capital femoral epiphysis, DDH, and CTEV. Okay, we are dealing with only these four major pediatric orthopedic disorders. Right. So, which of the following is a X-ray feature of Perthes disease? Increased medial joint space, metaphyseal cysts and rarefaction, lateral extrusion of femoral head, slip femoral head. Can anybody try attempting this answer? Who's doing internship now? You keep responding. Otherwise, I am not sure whether my voice is clear or net is unsecure.
Sir, voice is clear, sir.
Okay. So
It's good.
you might find it difficult to answer, but I'll explain you. I'll explain you in detail. So, which of the following is a X-ray feature or radiological feature is? Yes, increased medial joint space. True. Here again, it is except metaphyseal rarefaction of the metaphyseal cyst and rarefaction. Yes, it is seen. Lateral extrusion of femoral head is seen. Slipping of femoral head is totally a different entity. As I said, it is seen in slipped capital femoral epiphysis. So before going to this, I'll explain you what is Perthes disease. Perthes disease, you please remember, it is avascularization of the femoral epiphysis. You should know here clearly the anatomy. The black line, what you see is physis. Physis. That is a growth plate. So what is above that is epiphysis. Epiphysis. Okay. And this is metaphysis. There is no confusion here. This is the basic anatomy you should understand. Okay. So what happens in Perthes disease is this capital, why you call it is capital epiphysis is capital is head, isn't it? Femoral head is called as femoral capital. So capital epiphysis. So what has happened in Perthes disease, which is generally seen in male children between 4 to 8 years, and the cause is unknown. Cause is unknown. What is known is there is a lateral facial artery which gets kinked. So the basic pathogenesis is there is a temporary ischemia of capital epiphysis. So there is a difference between avascular necrosis of femoral head in adults. Please remember this. This is totally different. Here, this is avascular necrosis of femoral capital epiphysis, means in children. Just like you differentiate between rickets is in children and osteomalacia is in adults. Both causes vitamin D deficiency. Please remember. Similarly, avascular necrosis in adults is different. Avascular necrosis of femoral capital epiphysis in children is called as leg called Perthes, or to make it simple, it is Perthes disease. So what happens here? Here there is a lateral epiphyseal vessel which gets kinked. There is a lot of theories, will not get into that. So it gets kinked, your physis gets avascular, it becomes avascular. But because in childhood remodeling is possible, again the formation of femoral head is there in Perthes disease, but in adult it is once and for all lost. So what happens? I will come to head at risk signs later. Okay, it's not there. So these are head at risk signs. So one more important thing is in femoral capital epiphysis, what you see, this is cartilaginous. What you see on X-rays, when slowly this head forms and becomes a bone. So in childhood, between 4 to 8 years, you will see the only this part. This part is cartilaginous. What happens is there is a ischemia. There is a ischemia and this collapses. So the pathophysiology is once there is a avascular necrosis, again there is a remodeling and reformation of capital femoral epiphysis. So there is something called as head at risk signs. You should remember, eventually this head which gets avascular, as the age passes by up to 8 years, this again the head is formed. But if the head is malformed, the head becomes large or head becomes extruded out of the acetabulum, then early degenerative arthritis happens. Will not. So you can predict the hips which are going to early osteoarthritis, where the outcome is poor. Outcome of uh, Perthes disease is poor. How do you identify? How do you prognosticate? These are called as head at risk signs. If these any of these head at risk signs are there, means in childhood when you see a Perthes with head at risk signs, you are sure that in adulthood he will go for early osteoarthritis. Please remember, the femoral head, the hip joint will not be normal like any other adult if there are head at risk signs. You should remember and memorize this. It's very simple. These are head at risk signs. If these signs are there, you are very sure the head will not be normal in adulthood and you will go for osteoarthritis. What are those head at risk signs? We'll go one by one where you can remember. Gauge sign. You remember there is a punched out kind of lesion here. This V-shaped lesion, they call it as V-shaped lesion, V-shaped translucency in Perthes. In part of it is physis, part of it is in metaphysis. This is called as gauge sign. Please remember gauge sign. And look, and second is horizontally aligned epiphyseal plate. See, this is a physis, as I told you. This is a physis. Above that very thin white line you can see is epiphysis. So normally it should be in like this, obliquely oriented. Here what has happened? It is oriented horizontally. That again, that is at head at risk. So horizontally aligned plate, gauge sign, and more importantly, you see the calcifications in the lateral portion of epiphysis. See this. These are the calcification. And head is, you see, beyond the sternum. Head is beyond the sternum. Look at this. So it is lateralized. Please memorize this. This is very, very important because they will be asked one of the questions where all these are head at risk signs except similarly. So lateralization of the femoral head, calcification of the femoral, calcification of the epiphysis, diffuse metaphyseal cysts, of course, are not seen here, horizontally aligned physis and gauge sign. Okay. So this is one more important sign is sagging rope sign. This is sagging rope sign. It looks like a sagging rope, isn't it? Please look at this. Follow the arrow marks. A sagging rope sign is a very, very classical finding in Perthes disease. If you carefully observe, look at the femoral head here. Very big head, there is no neck. Big head means coxa magna. Coxa magna. No neck means, or short neck means coxa breva. Breva is what? Small. Longus and brevis, you know, isn't it? So coxa breva, coxa magna. Magna means large head. These are few signs of bold Perthes. For example, if you are given this X-ray, you know, for example, for sure, it is outside the acetabulum. It is almost subluxated, and head is malformed. Neck is short. They look at the tip of the trochanter, which is lower, and neck shaft angle is coxa vara. Coxa vara means hip is in varus. Okay, right. So again, one more important, I want to stress again and again, this V-shaped translucency is called as gauge sign. Gauge sign you won't get anywhere else. That name also you won't find anywhere. So this is gauge sign is seen in Perthes disease where head is at risk. Again, few signs I wanted to mention. Look at this. There is a translucent line here. Looks like a crescent. Crescent is half moon shape, isn't it? That is again seen in Perthes sign. So I want to show repeatedly. You will remember the images. That's why I am showing all this. So the wide growth plate, calcification here, metaphyseal cyst which was not seen in earlier X-rays. You can see very well. Horizontal growth plate. All these are head at risk sign, and that means you are finding a Perthes disease with a poor prognosis. All are true regarding Perthes disease except, okay, we'll go one by one. Osteonecrosis, osteochondritis, you don't know, keep it for later. Male preponderant, yes, male are more affected than female. Restricted abduction, yes, whatever is there, there is a irritability of the hip, means movements are affected, and hence there is a restricted abduction, you know it is there. Narrow joint space, it is not there because I told you your head is subluxated outside, there is a wide joint space, so it is ruled out. When you are not sure about osteochondritis, you can still rule out this by ruling out you are for sure knowing narrow joint space is not there in Perthes disease. Osteochondritis, again, this temporary vascular is seen in lunate bone, which is called as Kienbock's disease. There are many such osteochondritis. We will come to that one by one in a later. I will tell you few calcaneum, it is called as Sever's disease. Just remember one or two. Exhaustive list I will explain you sometime in any other presentation. Okay. Which of the following is investigation of choice for evaluation of suspected parties? Can anybody take this? It looks apparently simple.
MRI.
Very good, very good. You have read today, I think. Who is this?
Chaitanya.
Chaitanya, good. So MRI is the investigation of choice in Perthes disease. So when do you suspect Perthes is? Child between 4 to 8 years, male child comes to you with limping. Initially it is a painless limp. This is more important. Painless limp in a child between 4 to 8 years. So when there is a child was walking normally, then he develops a limp. So you should suspect Perthes. But if the child is limping since it started to walk, the child is limping since it started walking, means since birth. So you should suspect CDH or congenital dislocation of hip. Okay. So here a child between 4 to 8 years, male child coming with painless hip. So what is the investigation of choice? You see, you take an X-ray, you see it is normal. Better instead of doing ultrasound CT, straight away go for MRI because X-ray looks normal in the early stage of Perthes disease. Perthes disease is treated by important. I will explain you about the treatment in subsequent slides. So what is the treatment of choice? High dose of calcium. You can answer this. Anybody can answer this. Total hip replacement, relieving weight bearing, supervised containment of femoral head. Which one? So see, high dose of calcium is arbitrary. Total hip replacement, certainly not, because it is a disease of childhood. A replacement you do generally in adults. Okay. Relieving weight bearing, it is only sometimes, but definitely not a treatment. So most important is supervised containment of femoral head. So what has happened, what I told you is femoral head becomes avascular, then it becomes revascularized. So whole idea is you should always, the duration of disease of Perthes is 12 to 18 months. So during this period, you should not allow for the lateral subluxation. You should not allow the lateral subluxation because if it goes out, it is like a child left out of the house from the lockdown. It goes everywhere and grows abnormally. That's why it becomes a big head. So whole idea is you should contain the femoral head. You should contain the femoral head in the acetabulum because because there is a growth still left here. If you contain this, the normal growth of the femoral happens and a congruent ball and socket is developed eventually. So whole idea of treating Perthes disease is it is going to heal on its own. It is a self-limiting disease. So what is the treatment? What is you are supposed to do? You have to keep the femoral head all the time in the acetabulum. So how do you do it? You have to do it in two ways, either non-surgical or surgical. So whole idea is you have to keep the femoral head in the acetabulum all the time for next 2 years. 2 years you have to keep the head in the acetabulum without surgery or with surgery. We'll discuss the surgical options later. So this is what I was mentioning. The important lateral epiphyseal vessels, because of impingement on abduction, this goes for necrosis. This goes for necrosis. That is Perthes. Okay, look at this. Look at the normal side of the femoral head, very well grown femoral capital epiphysis. Look at this. It is disappeared. It is remaining as just a fleck of bone. And there is an increased wide space. Widened joint space is also called as Waldenstrom. Waldenstrom sign. If you can remember, it can be asked sometimes, but please remember it is a Waldenstrom sign. Just remember the name that it is associated with Perthes. You might not be able to remember, but increased joint space is also a sign of Perthes disease. So what are the classification or the stages? Look at the pictures very carefully. Look at this. Normal epiphysis. It has collapsed because of the avascular necrosis. Then here it is forming slowly. That is reossification. Finally it has healed. Look at this. Compare this with the picture A and picture D. It's almost normal, isn't it? You can achieve a normal hip if, only if, you contain this head in the acetabulum for 2 years. The disease heals on its own, but you have to keep the femoral head in the acetabulum for 2 years. Okay, this is called as catarrhal staging. Okay, this is called as catarrhal staging. Catarrhal staging. Please remember, catarrhal staging is in with respect to Perthes. Will not go into. There are 4 types, but will not go into the detail. It's not needed. So, how do you do? So, as I said, this hip is outside, going slowly outside. You want to keep it in the acetabulum. So you can do it by putting a brace. Look at this child. He is on the brace kept in abduction. By doing abduction, this goes inside the acetabulum. So this is called as abduction brace. Abduction brace. You can use the brace or you can use the cast. You can apply cast here and apply a bar, so you prevent adduction all the time. So this is very painful. Earlier people used to treat like this. A child has to be in the cast for 2 years, imagine. So there is a lot of psychological problems. Child has to miss the school. So nowadays it is not being followed, but please remember, abduction brace and bachelor's cast. It is also called as bachelor's cast. Whole idea is the hip is in abduction. Okay, but nowadays what we are doing, we are not doing that. We are not doing a casting or bracing for 2 years. Imagine a child being in the cast for 2 years. So what we are doing? We are doing surgery. What we are doing a varus osteotomy. Varus osteotomy means what? You remove a part of the bone. Okay. So put the head in varus. So head will be always in the acetabulum, but child also can keep moving. For till the osteotomy site heals within 3 weeks, the child can walk without any assistance. So this is a surgical containment. This is a surgical containment. This is a non-surgical containment. Okay. So whole treatment goal in Perthes disease is containment of the femoral head in the acetabulum, either surgical or non-surgical. So we'll go to slipped capital femoral epiphysis. So which of the following is not true? Males are more or more frequently affected. Extension is restricted. Commonly occurs during adolescence. Varus adduction and external rotation restricted. Can anybody want to attempt in answering this question? Okay, I will answer this for you. So males are affected, commonly occurs in adolescence, true, varus adduction and external rotation restricted. The answer is extension is restricted, means which is false. Okay, so all are true regarding slipped capital femoral epiphysis. So avascular necrosis may occur, don't know. Usually after 10 years, yes. Obesity is a risk factor, yes. Frog leg lateral view is helpful, yes. More common in females. So the answer is more common in females. So to make it more simple, today we are dealing with Perthes, slipped capital femoral epiphysis, and DDH. So these two are more in male, DDH is in female. Please remember this. So more common in female is a correct answer. Means slipped capital femoral epiphysis is seen in more in male children. So this is what I was wanting to tell you. Look at this. These are X-rays of a slipped capital femoral epiphysis. More important, there are important signs. I will come to that later. This looks normal, isn't it? So this is a frog leg lateral view. Frog leg lateral view. Look at the physis here. Concentrate on this. This portion is normal. Here it has gone backwards. Okay, this has slipped. So you in early slip or mild slip where pelvis with both hips X-ray PBH AP view is normal. Take a frog leg lateral view. Don't bother about how you take. Take a frog leg lateral view. You see there is a slip. 14-year-old boy weighing 78 kgs means certainly he is overweight. Hypothyroid. He is a hypothyroid. Might be one of the reason for the overweight. He has sudden onset of severe pain and restricted movements in the hip following the trivial fall. He has just fallen down with a trivial injury, just like getting down from the cycle or climbing the stairs suddenly without any severe injury. Trivial, it is a trivial injury. He is an overweight child, hypothyroid. So what is the most likely diagnosis? So see, please remember, for the fracture to happen, for the dislocation to happen, it should be major or severe trauma. Major or severe trauma. Perthes disease, unlikely because there is no history of trauma. Perthes develops without any history of trauma. So answer is slipped capital femoral epiphysis. Trithovan sign is seen in, you will not be knowing, I guess. But if you are read today, anybody has gone through pediatric orthopedics because I put a message today? Has anybody attempted reading? Okay. So Trithovan sign is seen in slipped capital femoral epiphysis. I will tell you what is Trithovan sign. Look at this. So Trithovan sign is a line, straight line is drawn along the superior border of the neck. So if a line is drawn along the superior border of the neck, a part of the head is above the line, means it is normal. Here the femoral head, all the femoral head is below the line, means this line is Kleen's line, if you can remember well and good. but this line doesn't cut the femoral head. Means no part of the head is above this line. This is called as Tritovan's sign. Tritovan's sign. Look at this. Tritovan's sign. Look at the line here crossing. The physis falls below the line. Normally, at least a part of the physis has to be cutting the line. So if it is not, then it means there is a slipped capital femoral epiphysis. So please remember Tritovan's sign. Then we'll go to, okay, slipped capital femoral epiphysis. I will explain you certain things about slipped capital femoral epiphysis. So what you please remember, it is common in male children, and it can happen in two types of body habitus. One is overweight child or tall and thin children. Generally between about 10 years, more in male, more in overweight, more common with hormonal disorders, especially hypothyroidism, hyperparathyroidism, and increased growth hormone. So these are the conditions where you get a likely possibility of slipped capital femoral epiphysis. Again, you please remember, you should remember this. So what happens here? This is a normal femoral capital epiphysis. In slipped, what happens? It slips below. It slips below and behind. So there are acute slip and chronic slip. Please remember this. Acute slip and chronic slip. Acute means it happens suddenly. Chronic means it happens over a duration. What is the treatment? There are very few questions on treatment, but you remember what is the treatment is, whatever is the position, you have to fix it with a screw. You have to fix it with the screw. What is the purpose of fixing with the screw is, you have to fuse the epiphysis. The fusion of the physis has to happen prematurely. Means this further slippage doesn't happen. So why this slip happens is because the physis is open. The whole idea is you have to put a screw across and fuse this. So once it fuses, there is no further slip. Acute and chronic slip. So always you remember, in acute slip, you can reduce it. You can reduce and fix it. In chronic, you have to fix in wherever position it is. Remember this. Acute slip, you reduce. Chronic, don't reduce, fix in whatever position it is there. Which of the following is true about DDH is dysplastic developmental dysplasia of hip. Earlier it was called as CDH, congenital dislocation of the hip. But it is better named as DDH because it is a spectrum of disease. It is a spectrum of the disease. In one end, it is a dislocation. In one end, it is an unstable hip. So DDH is a spectrum of the disease. Please remember that. Okay. So we'll come to which of the following is true about the DDH. Male gender is a risk factor. Limb in adduction, internal rotation, flexion in childhood. Femoral neck is retroverted. Ligamentum teres is atrophied. So I will answer you for this because you might have not read. I'll explain that later. So answer is limb is in adduction, internal rotation, and flexion in older children. Here, head is excessively anteverted. Ligamentum teres is hypertrophied. I will explain to you that with some pictures. So please remember, factors associated with DDH are female child, as I said, all F. female child, first child, family history is there already, frank breech, anatomical other anomalies like CTV, spina bifida. So please remember female first child, family history, frank breech, fetal abnormalities. There is one more, overcrowding phenomenon, overcrowding phenomenon or oligohydramnios. You are better knowing about oligohydramnios. Okay, these are the risk factor. But please remember, twin pregnancy is not a risk factor. Even here there is a crowding phenomenon, but twin pregnancy is not a risk factor for DDH. Okay, so what are the pathoanatomy? Pathoanatomy, if you remember, you will be easily able to answer some questions. So there are changes in the soft tissue, there are changes in the joint. So what happens? Soft tissue changes is whenever there is a head which is like, it has to be like this, it has dislocated. It has dislocated. Means what happens? There is a stretching of the capsule. There is a stretching of the capsule. Then what happens? There is a ligamentum teres here attached from the fovea of the head to the acetabular fossa. So this, because the head is dislocated, this becomes thick, hypertrophied. So there is a thickening of the capsule, there is a thickening of the ligamentum teres. Because it is empty, this becomes filled with fibrofatty tissue. So tissue migrating into the stomach. So fibrofatty tissue becomes full. There is an empty room which is completely occupied by the spider web like thing. So if you don't enter the room frequently, then develops a spider web, isn't it? So like that, fibrofatty tissue is developed. Then what happens? There is a iliopsoas muscle that causes, that doesn't allow the head to get into the, so this causes hourglass constriction. Hourglass constriction means there is a widening here, there's widening here. This because iliopsoas muscle which is attached to the lesser trochanter causes hourglass constriction and doesn't allow the femoral head get back into the acetabulum. Okay, so following is not, so again please remember in DDH you have to do screening test. I will explain to you about that in a minute. So you have to remember Barlow's test. I will explain that in a minute. Before that, you have to answer this question. Following is not a part of autonomy test. So there are autonomy and Barlow's test. Examiner thumbs rests on the medial thigh, very right. Examiner's fingers lie on the trochanter, true. Hips are flexed at 90 degrees, gently abducted. Yes, very right. Jerk is given to knee dislocate to exit. No. So yeah, this picture you please remember. You can see some YouTube videos also. Once you remember, you will never forget it. Barlow's means there's some mnemonic Baharlo, Baharlo. Or you go to the bar outside. You go to the party in the bar. So what you do, Baharlo means you want to dislocate the head. In the normal child, you should not be able to dislocate. You are not able to dislocate means it is an unstable hip. So Barlow's or Barlow means you are dislocating it. And one more important here is, how do you do? You dislocate by adducting. Both the thighs are close to each other. DAD. Barlow's is dislocating. You want to dislocate by doing adduction. Barlow's. Okay. If you are not able to dislocate means what? The child may be normal or the head is already dislocated dislocated. You can't dislocate already a dislocated hip, isn't it? So Barlow's, there is no jerk or cluck here. Heard means it is a normal or a dislocated hip. So that time you have to do ortholanist maneuver. So once it has gone out, it has to come in. So how do you get inside? By abducting. You remember this. By abducting the hip. By abducting the hip, you reduce it. So DAD, what happens to the hip? Second letters is what is the maneuver? AB is abduction, AD is adduction. By adduction you dislocate, by abduction you reduce. Am I clear? All the following are true regarding congenital dislocation of the hip, except, read the question carefully. So asymmetric thigh folds may be seen. Yes, correct. Gallagher sign, orthogonality test may be positive. Yes, correct. It may be bilateral. Correct. Look at this. Polyhydramnios is not a risk factor. It is a oligohydramnios. Means there should be crowding of the fetal parts. This is the answer. These some pictures you have to remember about the CDH or DDH. Look at this. This is called as Alice sign or Gallagher sign. You might, there are few questions which have been asked in the past. So please remember this picture. Watch the picture carefully. You will have a nice pictographic memory. So if you keep the limb adducted and flexed at the hip, see one is shorter. One is shorter. Means this hip is short, means there is a possibility of a CDH. This is called as Alice test or Gallagher sign. Okay, but there is a problem here. If both the hips are dislocated, this test is useless. This is useful only in unilateral CDH. Both are dislocated means again they will be at the same level. Okay. And one more important thing is, whenever you deliver a child in a labor room, always see that you are able to touch the thigh to the examining bed. So you should be able to abduct the hip till the thigh touches the couch. If you are successful or you are able to touch the thigh to the bed, that means this is an important screening test for CDH. So they might ask simple screening test. There are screening tests for CDH. So abduction, complete abduction is there means CDH is ruled out. Similarly for CTV, the foot, if you dorsiflex the foot, imagine or do it yourself. You dorsiflex your own foot so that dorsum of the foot touches the tibia. So if you dorsiflex the foot, it should touch the tibia. Means there is no CTV. These are two important screening tests you have to do in the labor room in a newborn child. Pollic harness. Harness is a kind of a belt. Okay. So Pollic harness is used to treat DDH, Perthes, SFE, congenital coxa. So we'll go one by one because we have already addressed important points of certain pediatric ortho common disorders. Perthes disease, as I said, you are doing a cast for 18 months or doing a osteotomy. Slipped capital femoral epiphysis, I told you, you have to fix it with a screw. So this is ruled out, this is ruled out. Coxa is also ruled out because you have to correct it by osteotomy. So what is remaining? DDH is a developmental dysplasia of the hip. So I will show you one diagram. These are harness. See, if you do bungee jumping or skydiving, they apply belt all around you, safety belt, isn't it? They are called as harness. Similarly, such harness is used here where the child's hip is kept in flexion, abduction, and external rotation. This is called as Paulic harness. Paulic harness used in the hip, which can be reduced easily. Which can be reduced. You reduce and keep this in position. Perkins line on X-ray is used for diagnosis. Certainly, no CTV, not Perthes, avian, it is CDH. Because we are dealing with CDH, isn't it? But I will show you a diagram of Perkins line. Okay, see, please remember these are very, very important diagrams, especially when it comes to CDH, okay, or DDH. Whenever I say, I mean say DDH. So these two lines are Perkins line. This H line is Hilgen-Reiner. Hilgen-Reiner. Easy to remember. You don't have to remember the spelling. Anything, if they give partly, you will easily recollect Hilgen-Reiner line or Perkins line. So what happens? So whenever you take a X-ray of a child suspected to be having CDH, you have to draw these two lines. One Hilgen-Reiner line goes to the triradiate cartilage. This is a triradiate cartilage. So horizontal line through the triradiate cartilage, Perkins line through the lateral border of the acetabulum. So it makes 4 quadrants, isn't it? So look at this. So normal hip, the femoral head is medial and inferior. So this is medial, this is lateral, this is superior, this is inferior. So please remember, normal head is medial and inferior quadrant. Look at this hip, which is dislocated. It is naturally dislocated, means it has gone up and outside, upper and outer quadrant, superior and lateral quadrant of the lines. Please remember, Perkins line and H line are used in CDH. Again, important radiological markers are there. Please don't really bother about this. Acetabular index. You remember one thing. See, if the acetabulum is like this, vertical, the head can easily dislocate. If the acetabulum is horizontal, head cannot go up. Okay, so acetabular index is high, means it goes on becoming vertical, means head is a possibility that it can dislocate. So as high acetabular index is a risk factor for CDH. Salter's pelvic osteotomy is done for the treatment of. So pelvic osteotomy, it says common sense, isn't it? CTV is foot. So it can be SCFE or DDH. Slip capital, you are not doing anything on the pelvic side because it is normal. In DDH only, there is a problem with the acetabulum. You have to do a corrective osteotomy. So answer is DDH. Salter's pelvic osteotomy is done in treatment of DDH. So this is one such diagram. Look at this hip which is dislocated. It is reduced and there is a osteotomy here. Osteotomy. The pelvis which is normal, it is cut here. It is cut, head is put inside and it is fixed. This is Salter's osteotomy. Please remember Salter's osteotomy in DDH. Okay. Von Rosen sign is positive in DDH. Huh? I will explain you that again in a diagram. See, what happens in a child less than 6 months? If a child is there with less than 6 months, you look at the pelvis X-ray, this head is not formed because it forms in 1 year. Femoral capital epiphysis appears in 1 year. So what is there here on X-ray? Only the femur is seen, no neck, no head is seen. But you want to still be sure whether there is a CDH or not. What you do, you have to do a lateral X-ray and draw a line along the femur. If it goes outside the acetabulum, means there is a CDH. So Van Rosen line is helpful when femoral head is not still formed. You cannot see that in X-ray. That is within 6 months of age. Within 6 months of age, when head is not formed. That is a Van Rosen line is useful in DDH. Bachelor's cast, as I said, I mentioned earlier in the previous slides, it is in the treatment of DDH. Similar to what you saw here, polyc harness, we apply cast all over. Cast all over. That is called as bachelor's cast. So all the following statements are true about DDH, except whenever there is a question like this, you should know the topic thoroughly, only then you'll be able to answer. So as I said, Perthes and SCFE on males, DDH in females. So more common in females, correct. Oligohydramnios is associated with increased risk of DDH. Yes?
Option 4.
Option
Will
4. Very good. Pregnancy is not a risk factor. It is not a risk factor for DDH. Okay, very good. So following, now we'll go to CTV. Quickly, I'll finish with few more questions. CTV. Again, CTV is very, very important. Many times they ask questions on CTV. Following muscles are used full in inversion of the foot, except wherever you are sitting on the stool, you move the foot where the sole has to see the ceiling. You try and move your foot inwards where the sole has to see upwards. So look at this. It has to be, muscles has to be, the foot is like this, means this is a great toe. It is more upwards. Means the muscles has to be in anterior or medial side. Okay. So tibialis anterior, yes. Tibialis posterior, yes. On the medial side, peroneus longus is wrong. Correct. Okay. EHL is again correct. Very good. Pirani scoring. Pirani scoring includes all except. I will tell you what is a Pirani score in subsequent slides. So the answer is protrusion of the cuboid bone. It is wrong. Pirani score includes medial crease. Okay. Look at this. So you remember Pirani scoring is used in CTV. So what do they see? What do they see in scoring system? There is a hind foot score and a mid foot score. There's no big deal. Please don't get confused. Watch patiently. It is not like GCS where EMV they're scoring up to 14 or 15. I don't know. But Pirani scoring is very, very simple. There is a hind foot score, mid foot score. So hind foot and mid foot. So hind foot, what happens? CTV is what? Congenital talipus equinus varus, equinovarus, isn't it? Varus in forefoot, equinus in hind foot. Okay, so hind foot equinus rigidity. How rigid is the equinus? So there has to be posterior crease. Look at your own foot. There are creases posteriorly. Means the normal movements of the ankle are there. Empty heel. You have to examine a child, then only will know. So midfoot again, medial crease, lateral head of the talus, and lateral curvature. So please remember, don't get confused. Pirani score is for CTV. It takes into the account of hind foot and midfoot. Midfoot means there is a medial crease. Hind foot means there is a posterior crease. The heel is in varus means there is an empty heel. Okay, it is HEL. Lateral head of talus is subluxated on the dorsum. So please remember, don't try to get into the nitty-gritty of the scoring system. Pirani score is with CTV. It requires hind foot and midfoot scoring from 0 to 1. Mild, moderate, severe, maximum 6 also is not so important. Okay. So which of the following is not true about manipulation methods to correct CTV? It's very important. Please read the choices very careful. Which of the following is not true? Okay, in correcting CTV. Involves serial plastering, serial casting below knee POP. Don't know. In Kite's method, deformities are corrected sequentially. Sequentially means one after another. Ponseti method has a success rate of 90 to 98%. Ponseti method of correction involves cave. Please remember cave. Cavus adduction varus equinus. Very easy to remember. CTV cave, CAVE. Cavus adduction heel varus and equinus. This is the order of correction. So the answer is so simple, it is given. So never you apply a below knee cast. It is always above knee cast for two reasons. One is the cast should not slip. Second is by keeping the knee in flexion, you will relax the gastrocnemius and able to correct the equinus. Kite's method. Earlier we were following Kite's method, now we are following Ponseti method only. Please remember, the latest and the time tested method is Ponseti. This is the only method which gives 98% correction of the feet without surgery. So Kite's method will not go. Only remember Kite's method, they were applying pressure here, calcaneocuboid joint. Now the pressure is applied at the talar head. Ponseti is talar head, Kites is calcaneocuboid. So basic Ponseti, what is a Ponseti treatment protocol? Manipulation and cast application. So you have to manipulate the feet, try to correct it few times and then you apply the cast. So this is the typical above knee cast. So you apply cast every week immediately after the birth. It's very important. Earlier they used to wait for 6 months. Now it is immediately after birth. After 5 to 6 cast, you do tenotomy of the Achilles tendon. Then after that you apply a abduction brace. So child is still in 6 months when it is not walking, isn't it? Once it is walking, you can use, you have to monitor the child till 7 years. You can use foot abduction brace in the night, and daytime if the child is walking, you have to use the CTV shoes. So all of the following are described procedures of CTV, except is, remember, Salter's osteotomy. As I told, Salter's osteotomy is a pelvic osteotomy in CDH. All are true about atypical CTV. You have to remember something called as typical CTV and atypical. Atypical is associated with neurological, muscular or osseous problem. Neurological means there can be myelodysplasia or spina bifida. Muscular means it can be arthrogryposis multiplex congenita. Osseous means there is an abnormal bony fusion. So these are atypical. These are atypical, very difficult to correct. Typical is idiopathic. Idiopathic, you don't know there is any underlying cause. There is no underlying cause which is detected is idiopathic. So all are true about atypical CTV. Foot is flexed downward. Yes. Sole crease is not found. Difficult to treat than atypical. Correct. May occur due to neurological disorder. Yes, correct. May be associated with meningomyocele. All these are correct. Except sole crease is not found. Wrong. There is a deep crease. There is a deep crease in atypical CTV. Triple arthrodesis. So I will show you one diagram so that you will remember easily. Triple arthrodesis means three joints. This is talus. Talonavicular joint is fused. Talocalcaneal joint is fused. Calcaneocuboid is fused. Three joints are fused. Triple arthrodesis is treatment in neglected CTV. Neglected CTV. Please remember this picture. Very, very important. Talus is fused with calcaneum. Calcaneum is fused with cuboid and talus and navicular bone. So we'll go back to this question. Triple arthrodesis involves. It is very confusing if you do like this. So please remember, go read and read very, very patiently. Tibiotalar is not involved at all, so this answer is wrong. Ankle is not involved in triple arthrodesis, so the answer is this. Talocalcaneal, talonavicular, and calcaneocular. In correction of the clubfoot by, you know why it is called as clubfoot? You remember, you know the golf club. Your foot looks like a club. It is a golf club, not your disco club. In correction of the club foot by manipulation, in club foot correction by manipulation, which deformity should be corrected first? It's very, very important. Always correct forefoot adduction first. If you correct the equinus deformity, say for example the foot is like this. If you try to correct the equinus, there is a break in the midfoot. So foot becomes like a rocker bottom foot. Rocking chair. So never correct equinus in the beginning. Equinus has to be corrected always in the last, and first it has to be forefoot adduction. Okay, that's where we come to end of this session. I know this is little unconventional topic, but invariably questions are asked. It is difficult, but you anytime you go through and you don't understand, unlike any other topics of orthopedics, this is, I believe, little atypical, unconventional. But always you read and get back to me. Feel free to ask questions. I will clarify. Okay, Chaitanya, only Chaitanya is still there, and Yadgiri. Yadgiri.
Yes, sir.
I understand the topics are little difficult, but well, yes, you have to go through the endurance, torture, whatever you call. Okay,
Okay, sir.
I'll upload this